So what I'm going to do is talk a bit more about kind of outcomes, what can happen in terms of mental health and cognition, and primarily from the point of view of children and young people. So just in terms of who I am, so I'm a consultant pediatric neuropsychologist in Glasgow in the Royal Hospital for Children, and also have a research team who primarily work in epilepsy, but we have done some meningitis research in the past. So I kind of see kind of children with all causes of pediatric brain injury and neurodevelopmental disorders. So meningitis and infectious diseases are a part of what we do. But actually, the number of children see with meningitis has dropped significantly, and I'm going to just show you some of the reasons for that, which is very positive. So, one of the things that's different when you're taking a developmental perspective on neuropathology is that there's a great deal happens, from the moment of conception, really right across pregnancy and year one of life. So as well as thinking about, traumatic brain injuries and neurodevelopmental disorders, we often have to think about the effects of things that happen very early on while your brain's being built. And often those things won't manifest or express themselves till much later in development. And, those can be, things like subtle gene mutations that might lead to epilepsy or to autism, but which won't be evident for some time, through to exposure to toxins while you're still in utero. And those could be viral things, or they could be prescribed drugs or alcohol or a range of infectious causes, through prematurity, problems around the time of birth. But really from the time you're born through to your first year of life, that's when you're more likely to have and contract meningitis. So really, for me, I often think about meningitis as a problem that happens very early on in the life cycle. I know that there can be spikes later on, but it's something that often happens in the neonatal period. Now, there's been a big change in the incidence and causes of meningitis during the 23 years that I've been in practice, largely due to the successful vaccination programs in the UK and in most Western countries, which will be very different from Dr. Michael's experience in developing countries. But really since the 1990s, we've substantially reduced the cases of bacterial meningitis. And also things like the MMR have also reduced the number of viral cases. So now about 70% of viral pediatric admissions are now in infants less than 90 days of age, with an incidence of around 70 per 100,000 births. So given this talk's made me go look at the literature again recently, which has been of interest, because I've always kind of thought about viral meningitis as largely being benign, depending on the agent that causes the infection, in comparison to the bacterial meningitis. But there is some limited evidence in studies of adults of lower quality of life, and Dr. Michael just showed us one of those studies. And also that some survivors can have more significant mental health issues. And I guess that's largely due to those who've had more of a kind of brain invasion and some brain damage. But there's been at least one meta-analysis. A meta-analysis is where doctors look at all the studies in a particular area and then try and add up all the patients who've been exposed to something to look at the effect. So you're just trying to not just look at a particular study, but look at all of the studies, all of the evidence. And so this is one of the better quality meta-analyses, looking at 39 studies of cognitive outcomes after meningitis. And these authors found significant evidence that surviving bacterial meningitis can lower your IQ and alter your development. And that's really important because IQ tests are one of the most reliable ways of working out what the impact is going to be across your lifespan, not only in terms of mental health and cognitive development, but also physical health. So it's a really important thing to look at. but there was no evidence that viral meningitis had any meaningful cognitive impacts. So I think that's reassuring that, usually, particularly in developed countries, viral meningitis doesn't have a significant impact on cognitive development. Now, as many of you probably know, that bacterial meningitis carries a higher rate of mortality and morbidity, and the kind of classic outcomes tend to be that around 10% mortality with bacterial meningitis, and a further 10% likely to have neurological problems such as epilepsy or hearing impairment or visual impairment or more significant learning disabilities. So that there's really been evidence of of brain damage that's going to have an impact across the lifespan. And these two studies just show that kind of change in the kind of incidence and etiology. So on the left, here's a paper published in Archives of Disease in Childhood, and this was back in 1993, and related to a 10-year study across the 80s in Nottinghamshire. And really, the top left hand is showing the graph showing the incidence in neonates, so that's in month 1 of life. And then next to that on the right is the first year of life. So you can see that the incidence of bacterial meningitis is quite high, both in month 1 and in the first year. And then the bottom left shows from 1 year to 5 years. So there's still there's far fewer cases, but there is something that still manifests in younger children. But in the bottom right, that's aged 5 to 16 years, so a very low incidence. And this is going back to the 80s. So very much bacterial meningitis was something that affected infants in the first year of life, which thankfully now is much less of a problem due to the successful implementation of several of the vaccines. Whereas on the right-hand side, this is looking at a paper in The Lancet just a couple of years ago, showing that enteroviruses and herpes viruses are the most common causes of viral meningitis in adults. But I think, as Dr. Michael makes the point, it's very hard to diagnose, and looking at the numbers with detectable causes of meningitis, actually 42% of that cohort had an unknown cause. So it continues to be very hard to always identify the actual pathogen that's causing the illness. And again, as Dr. Michael says, the use of PCR has led to a big increase in detection. So now the rate of detection of the pathogen is ×7 compared to in 2003, and that's probably higher than it was in 2014. So the chance of finding the cause is much higher. So thinking about outcomes after childhood meningitis then. So there was a number of outcome studies, which, if mainly published more than 10 years ago, they'll report on the children with higher levels of bacterial infection, where you're more likely to have complicated disease. So that's where you might have, a need for more significant neurological intervention, and where you might have seizures. And they all tend to show this kind of figure of about 10% mortality and a further 10% with neurological disorder or limb amputation. But beyond that, equally, all these studies tend to show that around a third of survivors do have significantly lower quality of life compared to UK population norms. But much less is known about outcomes with viral meningitis in children. So there's still a belief that those who develop mental health issues, it's less likely to be due to brain damage than in the children who had the bacterial infections. But what we do know also is that children admitted to hospital with any serious disease tend to have higher rates of psychological adjustment issues and emotional and behaviour problems than community controls. So we have to bear in mind that there's the two things that go on. One is that your brain can be damaged, and that can lead to significant changes in how you process emotion, in your memory, and how you feel about yourself. And that can also cause low mood and trauma reactions. But the other thing is just about the experience of what you've been through, which can often be very significant. So in contrast to the kind of meningitis that we see now, encephalitis is often associated with much more significant cognitive, emotional, and psychiatric problems. So it's now quite rare for us to see children after meningitis. Obviously, some children do still have severe disease, and that there are still some cases of bacterial meningitis. But what has become more of a problem for us in terms of infectious causes tends to be things like the immune-mediated causes of encephalitis. So just to show you, we did one of these outcome studies, which we published about 10 years ago. Again, just to try and look at, what happens in terms of quality of life and emotion difficulties following meningitis. So we wrote to over 346 survivors, consecutive survivors in our hospital, and from 1991 to 2007 to one Glasgow hospital, and about a third of those actually responded and filled out the measures. And just to count, there was no difference between the responders and the non-responders in terms of their socioeconomic status, or on how old they were when they were admitted to hospital, or how long they stayed, or indeed the causes of their meningitis. So they were fairly similar. The only difference was that there was more girls than boys in our responder group, and they were slightly older. But a reasonably representative sample of responders. And from that group, we had complete case records on 100, and on the left-hand side, you can see some of the causes of the meningitis. So quite a high rate of the Neisseria meningitis and strep pneumonia, but still a large group of cases where the pathogen wasn't isolated. And then below that, in terms of complications, there was 36% had a complicated treatment course. So that was where they had a seizure or need for ventilation or inotrope support. So probably quite a high rate of complicated disease. And similarly, quite a high rate of visual impairment, 27%, hearing impairment, 19%, and learning disability, 16%. And what did we find? So we found that a mean of 8 years post-illness, a third of parents and a fifth of teachers reported clinically significant behaviour and emotion problems on the Strengths and Difficulties questionnaire. So the SDQ is a very widely used measure of emotion and behaviour problems in childhood. So those are really quite high rates, and it's normal for parents to report higher rates than teachers, really regardless of the condition that we're studying. So that's quite a high rate. So so even in people who've not had very severe disease, who've not had neurological complications, there is still a significant number of people who will have these emotional and behavioural difficulties, which across the lifespan can then evolve into more significant mental health problems. And again, as a group, they did have significantly lower quality of life using the pediatric quality of life scale, which is probably the gold standard in terms of quality of life. So the people who had a learning disability or visual or hearing impairment had poorer quality of life. So that's not surprising. But also those who were kind of lower in resources, so people in the kind of lower end of socioeconomic status, that was also an independent predictor of behaviour and emotion problems. And particularly the further away you get from having disease, the more these other life factors can impact on kind of emotion and behaviour issues. So acute disease complications were associated with later epilepsy and learning disability and visual problems, but not directly with the psychosocial outcomes. And I guess the point there is that, and this again goes for kind of all causes of brain injury, that the closer you are to the actual illness you've had, the insult that you've had, the more that it's the actual brain injury that's directly impacting on how you feel and how you do. But with time, other factors start to become really important too. The family that you're in, the resources that you can access, the kind of community supports you get, the kind of support you get at school. So all these things start to become more important with the passage of time from the initial illness. So when we're thinking about adjustment issues following severe illness, so in this talk I'm emphasizing kind of pediatric presentation. So and I guess many people on the call may have had meningitis when they've been older, but for us the issue of PTSD is less prevalent. Obviously, if you've been very ill in infancy or early in your life, you're less likely to recall these experiences. And so post-traumatic stress disorder, for example, does require some recall of the actual events around your illness or hospital care. So mental health disorder, of course, can occur for many reasons. So, as I said earlier, if you've had some damage to your brain, that will impact on your brain's ability to just to tolerate stressful experiences, to manage mood, your experience of anxiety. All these things become something you have to relearn, and the threshold for you to experience anxiety or enter a kind of lower mood state is lower. And we're also balancing that against your actual experience at the time of your illness, but also just how your life goes. So the same things that lead to poorer mental health for all of us clearly continue to be an issue for children after who've had meningitis. So sadly, when you've had one traumatic event, you're more likely to react to life stresses with more difficulty than if you hadn't experienced early trauma. So if you've had one traumatic event that's caused a kind of traumatic reaction, it actually increases your vulnerability to respond in a more kind of difficult way to other life stresses. And this is why it's really important for us to think about the kind of total environment, how a family functions, and how school and other systems accommodate to support a young person. And often with early diagnosis of meningitis, most people will recover, and you're less likely to be coming to clinic and less likely to have any difficulties recognised. So often we can be asked by other teams within CAMS, the Child and Adolescent Mental Health Service, to give an opinion on a child who's presenting with difficulties where they've reported that they did have meningitis at an early age, and whether we think it could have been significant or not. But it's also important to remember that most children will recover quickly from meningitis, particularly viral meningitis, and won't present with cognitive problems or mental health disorders. So most people will recover very quickly. And there's not really enough coverage within the medical literature on resilience. So it's really important that we don't just focus on the prevalence of mental health issues, but also consider what was it that actually helped some people and some families to recover quicker? What are the resilience factors that we should try to recognize and also try to intervene with? And it could be things like with parents, trying to spot the parents who may be at risk of developing post-traumatic stress reactions during their child's hospital stay, because actually working with the parents could be a major vehicle of promoting better outcomes for the child. So just worth acknowledging that people react very differently to traumatic events. Most people will recover in time. So most of the kind of traumatic events people experience are normal. They're kind of normal, natural things that we go through. They're not pathological. So obviously, if we go through a life-changing or life-threatening experience, it's normal to feel overwhelmed, to feel shocked, to have kind of detached or dissociative reactions, to feel anxiety, to have sleep problems. But lots of these things will be transient and will dissipate with time, and that's what we would expect to happen, because your brain has to make sense of what's happened to you. You want to review it, you want to learn from it, you want to tell yourself that you can survive something like that happening in the future. So horrible things to go through, but for most people, natural recovery will mean that you will recover in time, and using the relationships around you, using the resources around you. But for some people, you can get stuck. For some people, you're just stuck dealing with some of the really terrible symptoms you can get with PTSD, and that's when you would need help, when it becomes chronic and more difficult. I'll come on to that again in a wee minute, but just to say that children can obviously present with the full range of mental health problems seen in adults, so they can have PTSD, and diagnosing it in young children is more complex because they often can't report the kind of problems that adults can. So often we'll see it expressed in play. So you might see traumatic reenactments. You might see children trying to act as a doctor or nurse and trying to show what happened to them through a doll or through other aspects of play. It could come out as increased aggression. So there's many ways that we have to think around behaviour patterns that might express underlying trauma in young children. But as I said a moment ago, it's really important that we consider the adjustment of parents who've shared a highly traumatic event, because really the adjustment of parents is a really key moderator of how young people will do in the long run. So family functioning is really important in the recovery of children to a traumatic event. And I found this study earlier on today, actually. I was just thinking a bit more about this, and this is a major study published by Belufi et al. And they looked at the parents of 272 children admitted to a pediatric intensive care unit for longer than 48 hours. And this wasn't just for infectious neurological diseases, but all causes. And they found that a third of those parents presented with acute stress disorder, and 20% with full PTSD at follow-up. So when they came back to clinic for follow-up, there was a really high rate of traumatic reactions in these parents. And again, there's not particularly a lot of awareness or help for parents to adjust to these extreme experiences. We see this also in epilepsy. A lot of parents, when they see their child's first seizure, think that their child's going to die, and a lot of parents will develop kind of undiagnosed and unrecognized traumatic reactions in the context of thinking that their child might die. And in this study, indeed, they found that the parents' belief that the child could die during admission was one of the key things that predicted PTSD development. But interestingly, objective measurement of disease didn't predict PTSD. So it actually wasn't because of how ill your child was. It was your belief about what might happen to your child, and also other emotions such as feeling guilty that you've done something wrong or that you couldn't protect your child. So we really have to take a kind of family perspective when we're thinking about the trauma that occurs in young children. Hold on. Okay. So PTSD then. So I think Charlotte just gave a really lovely explanation in terms of the experience of PTSD, which really is a severe mental health problem. And luckily, it is something that is very remediable. There are very good psychological interventions for PTSD now, exposure-based therapies, cognitive behavior therapy, and actually the probably PTSD treatments have got one of the strongest evidence bases in psychological intervention. And there's kind of main classes of symptoms. So you can have hyperarousal. So that's when you will notice lots of changes in your breathing and how you feel inside. You can be quite sweaty. So your fight or flight system's activated. And you can have that to both internal and external cues. So it can just be because you're thinking about what's happened, you're having a flashback, or it can be around something that you've seen, something in your environment has reminded you of what happened to you. And you've got this hyperarousal state going on that's really, really difficult. It makes you kind of want to either fight or flight. You want to run away from it. And if you have to stay in the situation, that's often when you can have these more kind of dissociative type reactions. Also, avoidance. So any situation that reminds you of the event, and it's not obvious things, so it might not always be. It could be something like a hospital ward, or but it could be anything. Our brains. We work in mysterious ways. Often the associations we can have towards an event that's happened to us could be really surprising to others. So the avoidance, the range of avoidance symptoms we can have is very individual and can take a while for actually the individual to recognize themselves. That's again one of the reasons why a therapeutic situation can help us just to pinpoint what might be risk situations. And then intrusion symptoms. These are the unwanted thoughts or memories related to the traumatic experience, and they can be very vivid and distressing. So it's not just letting your mind wander to kind of think through what's happened. These can be very intrusive, very unwanted, very vivid recollections, as if you're back in the moment, back in the situation you were in. And there can be lots of sensory aspects to that, so smells and colors. So it's very, very powerful memories that can be very distressing. I remember speaking to some police officers when I was a trainee. I did a forensic placement, and one day a week I worked in occupational health with Glasgow Police, and I'd speak to a few officers that had been involved in the Lockerbie disaster when the plane came down over Lockerbie all those years ago, and learned a lot about how they dealt with kind of trauma, but many of these officers just never really got over it, and could describe even 20 years later the experience of what they saw as if they were back in the moment. So PTSD is a very severe problem, and we only diagnose PTSD when there's chronic severe symptoms of hyperarousal and avoidance and re-experiencing that have a pervasive impact on day-to-day function. So what's much more common is to have quite significant anxiety and adjustment problems following a traumatic event. So you can have panic attacks, or a feeling that you're going to become panicky, have extreme fatigue, you can have mood disorder. But it's only when it reaches a certain threshold we would diagnose PTSD. And the problem there is that to get help, you often need to have a severe mental health problem, whereas a much larger group of people will have kind of mild to moderate mental health issues, but it's much harder to get help. And that's the kind of last thing I want to talk about is, where do you get help? So for people who are under 18, there's child and adolescent mental health services in every region. But again, this has changed during my career. There's an increased emphasis on severe mental health problems. So when I started out, CAMHS would accept referrals for probably quite mild to moderate mental health difficulties, or early emerging neurodevelopmental issues. But now I think it's really quite hard to have a referral accepted. I think it's the same issue for adults as well, with primary care CMHTs. I noticed that the government has a strategy where they're looking to spend a lot of money on primary care capacity, but most of it is going into community partnerships, and I'm not sure that they're actually going to increase the number of psychologists and psychiatrists greatly, but there's going to be a lot of investment in partnerships with local authorities, with voluntary community and social enterprise providers. And I think that's great. I think building up the suite of psychosocial care opportunities within your community is a great idea, but I think there does need to also be significant investment in psychology and psychiatry who are going to offer the actual evidence-based interventions for people with more significant problems. For children, education is a really important context. So if you get school right, that's a major source of social education and social integration, and helping teachers just to understand if there's any neurodevelopmental issues to do with meningitis, and helping to scaffold a child's early school entrance, just because often it'll be at that stage where a little bit of help is going to go much further. But there's generally very little support or recognition for parents who may be experiencing adjustment problems after the child's been admitted with a severe illness. There is pediatric psychology increasingly in hospital settings, but again, you'll only come into contact with those if the treating physicians recognise that there's a significant problem that requires help at the time. So I just want to make the point at the end that for young people who've had more severe disease, where there's likely been some neurological impairment, likely some cognitive difficulties, neuropsychological assessment can be really important, but can be hard to access too. So that's usually within a hospital, and would usually require your treating physician to have kind of flagged you as someone at risk of these kind of problems. Okay, so I think let's talk for a wee while. So thanks for your attention.